The purpose of this video is to review steps for surgical treatment of shoulder subscapularis tears. In this repair, I'll be utilizing Smith & Nephew instrumentation and implants. I will discuss portal placement and technical aspects of the procedure while the patient is in the lateral decubitus position. With the patient in the lateral decubitus position, the bony landmarks of the shoulder are defined. The acromion and clavicle are delineated here. The humeral head is palpated and the posterior portal is marked at the equator of the humeral head. The lateral portal is marked at the posterior aspect of the acromioclavicular joint. The anterior portal is just lateral to the coracoid. The footprint of the lesser tuberosity is evaluated while the arthroscope is in the posterior portal. Note that there is a blue suture in the biceps long head that has already been cut. A significant portion of the insertion site is involved within the subscapularis tear. After the standard portals are established, an accessory subscapularis portal is created. This is located approximately 3 finger breadths inferior and lateral to the rotator interval portal. A needle is utilized to identify the intertubercular groove prior to placement of the cannula. Note that the needle should be parallel to the anterior cannula and perpendicular to the humeral shaft. The needle is then marched laterally off the humerus and then back again to confirm the depression of the intertubercular groove. The accessory portal is made and the 5 mm clear track cannula is inserted. The cannula will engage the bone and then ride up into the subacromial space at approximately a 30-degree angle while viewing through the lateral portal. While viewing through the lateral portal in the subacromial space, the subscapularis tear is not completely evident. An arthroscopic scissor is introduced to split the lateral coalescence of the supraspinatus and subscapularis to improve visualization of the anatomy of the footprint. Notice the superior leading edge of the subscapularis and the anterior labrum, the glenoid, the humeral head, and the lesser tuberosity. A 4.5 mm awl dilator is introduced, followed by a 4.5 mm twin fix ultra HA suture anchor into the medial footprint of the lesser tuberosity. Next, an AccuPass suture shuttle is introduced through an accessory portal and passed through the subscapularis tendon twice in order to create a horizontal mattress suture. The second set of sutures are passed through the rotator interval that was previously split with the scissors and tied through the lateral accessory portal. A suture limb from each arthroscopic knot is then retrieved through the rotator interval portal. The two suture limbs are loaded into the 4.5 millimeter footprint Ultra anchor, and a clamp is placed on the suture limbs. Next, a 3.8 millimeter tapered awl is introduced through the anterior rotator interval portal to the intertubercular groove laterally. The footprint is then inserted into the bone. The anchor is malleted into place and the individual limbs traversing through the anchor are tensioned after the implant is in place. The interlocking plug is advanced into the eyelet, trapping the sutures within the body of the anchor, giving suture slide independent of bone quality. Sutures are cut The camera is then placed back into the glenohumeral joint to confirm the subscapularis repair. The arm is then taken down and range of motion is confirmed to conclude the case. Following the surgery, patients are advised to wear a pillow sling for 4 weeks. A regular sling is applied for an additional 2 weeks. External rotation is limited to 40 degrees for the first 4 weeks. At 6 weeks, active range of motion may begin and external rotation may be progressed to 60 degrees. At 10 to 12 weeks, resisted internal rotation and strengthening may begin.